thank you for that kind introduction, Russ. And I'm so happy to see so many faces here today. We've been prescribing injectable opioids at Crosstown through the Naomi and the Salome study and the treatment program supported by Providence Healthcare since 2014. And I've never been more hopeful that we're going to be able to finally reach some of the most vulnerable and marginalized folks in our society who've been victims of the opioid crisis that we're facing. There's so much more that we could do, and we're going to talk about one thing that is going to be happening in the coming weeks, months, and years. So I don't have any conflicts to report. Number of people to thank our patients and the participants of our Salome study, and I particularly want to give a shout out to our principal investigator, who was the lead on Naomi and Salome, Henya Yoveda-Yokas. So I'm going to cover some treatments for opioid use disorder, injectable diacetylmorphine and hydromorphone, and some evidence from randomized control studies, the results of Salome and why that study was done, briefly about politics and policy, and optimism, and just having all of you in this room gives me optimism. So as we know, opioid use disorder is a chronic relapsing disease. Oral agonist treatments, including methadone, Suboxone, slow-release oral morphine, work, but they don't work for everybody and not all the time. There's clinical evidence now from Canada, Europe, showing that injectable diacetylmorphine is effective, feasible treatment approach. Yes, we have oral options, but these don't work for everybody and not all the time. And with oral options, it really is a limited menu. Abstinence or detoxification only really has been discredited. Suboxone, methadone, Cadian are all good options, but injectables are also evidence-based, and we'll discuss that, but we need every tool in the toolkit to meet this problem. And I don't know, Nadia's going to be talking about our new provincial guide for injectable treatments, but injectables are just part of the continuum of care. So we started at Crosstown as part of the Naomi study, the first prescription heroin study. There was also a site in Montreal. And with the results of Naomi, there's now a Cochrane review published in 2012 showing that there is abundant evidence to support injectable treatment with prescription heroin. 8 randomized control studies at that time. All studies comparing heroin versus any other treatment showed favorable effects of heroin, all of them. Adverse events were more frequent in the heroin group, and therefore supervision of the treatment is recommended. And there was benefit in terms of retention, reduced street drug use, illicit activities, and there's also reduced mortality. The patient profile was those not benefiting, that is, continuing to use street opioids. And there's also cost effectiveness. Not only is diacetylmorphine and injectable hydromorphone are more effective than methadone, it is also more cost effective. And when you can provide better outcomes at lower cost, a treatment should be expanded. And that's why we're on the verge of having injectables expand in British Columbia and across Canada now. We estimate that the cost for somebody using illicit opioids on the street is at least $45,000 a year, and for us to provide prescription heroin to somebody at Crosstown is about $27,000 a year. So the savings is significant. And while this is an intensive treatment, there's nothing else that will work for some folks. And an ineffective service is inefficient and cannot be cost effective no matter how cheaply it is delivered. And Cochrane himself said that back in 1972. So why did we run Salome? And we had tried to access diacetylmorphine through Health Canada's Special Access Program when people were leaving Naomi. But we were turned down at that time. Fortunately, to the support of Providence Healthcare, the clinic remained open and patients were transferred to oral methadone. Suboxone was just becoming available then, so there were a few that attempted Suboxone. But in Naomi, there were 25 of the participants in Naomi received hydromorphone, and that was to test for heroin metabolites in the urine. And surprisingly, the blinding was not broken. People that were receiving hydromorphone could not distinguish which drug they were receiving. And even people with extensive experience with illicit heroin were not, thought that they may have been receiving heroin. And the treatment effect was preserved. Hydromorphone in that small sample, not powered to draw any conclusions, but it suggested that hydromorphone could be a treatment option. And of course, hydromorphone has the advantage that it's licensed as an analgesic and available to Canada and is a benefit on pharmacare. So Salome was done to test, is hydromorphone as good as prescription heroin in this population that continues to use illicit opioids despite attempts at the standard oral treatments. Non-inferiority studies can be controversial, but because there is an ancillary advantage of hydromorphone in that it is commercially available, there is a sound rationale for running this, for asking that question. This is the profile of folks that we recruited into Salome. People had to meet the diagnosis for opioid use disorder using DSM-4 criteria at that time. They had to be 19 years of age, 5 years of opioid use, regular opioid use in the past year, at least 2 episodes of opioid treatment, one of which had to be substitution treatment or agonist treatment. And they needed to have poor physical, psychological, mental, or psychosocial functioning. And within that group, on average, people had been using 15 years and had had 11 attempts at treatment. So using those guidelines, and Nadia will probably talk about the current guidelines, but using those guidelines, I think we were setting the bar too high. The blinding was not broken, so in the Salome study, people were unable to distinguish which drug they were receiving. And this will be interesting. I want to point this out for folks that may be prescribing hydromorphone or working with folks who are receiving hydromorphone. At baseline of Salome, 83% of the participants indicated they would prefer to be randomized to prescription heroin, but asked if only hydromorphone was available when they started treatment. 82% of folks said they would take that. I think ultimately we need both drugs, but today we have hydromorphone. This may be the only slide I need to show you from Salome. The number of, on the x-axis we have the number of days in the prior month, so 30 days in the month, and then the 6-month treatment time in Salome. When people start with us, they're using illicit opioids basically every day and multiple times a day. And by 6 months, that's down to 5 or less days a month. This is the statistical analysis from Salome. I won't go through it in detail, but we've got days of street heroin use in the prior month, days of street opioid use in the prior month, and the proportion of urines positive for street heroin metabolites, and broken down by intention to treat and per protocol analysis. And ultimately, we can conclude that hydromorphone is as good as diacetylmorphine. This slide is about retention and care. So it's time to the first 30-day treatment interruption with the probability of staying on treatment against 6-month time in treatment. And whether you use intention to treat or per protocol, our retention is about 80%. So that's remarkable retention for any health intervention. So these are some secondary outcomes. I would like to point out that when people start with us, they were engaged in illegal activities at least half the days out of the month, 14 out of the last 30 days, and whether they're receiving hydromorphone or diacetylmorphine, that's down to a handful of days, 4 or less by 6 months in treatment. This slide shows average dose of diacetylmorphine or hydromorphone in a number of studies. And our average dose of the diacetylmorphine per day was 506 milligrams, of hydromorphone 261 milligrams. And the doses aren't, they're all in line. There's a little bit of variation, but. So we can conclude from Salome that where diacetylmorphine is not available, hydromorphone could be offered as an alternative treatment within a supervised model. And in the broader context, Salome has provided evidence to support that supervised model. So moving on to policy, supervised injectable opioid agonist treatment is just part of the continuum of care. It's safe, it's effective, it's cost effective. Looking at the data, there's no controversy. When people were leaving Salome, we were able to get access to diacetylmorphine through Health Canada's Special Access Program. And unfortunately, it wasn't as easy as that, because we had a former federal government decide to oppose access to what is just a pharmaceutical treatment, labeling it as something else. I would point out that when we provide diacetylmorphine, it is pharmaceutical grade treatment. Heroin is something else. It's a slurry, a mix of compounds. Yes, there used to be a lot of heroin on the street. It's mostly fentanyl now. But we had support at all levels of government here in British Columbia. And we ultimately won an injunction in the BC Supreme Court. And we started to provide prescription heroin in November of 2014. And not long after that, we've had declaration of a health emergency here with opioid overdoses declared in April of 2016 by our provincial health officer, Dr. Perry Kendall. And injectable opioid treatments, I'm very encouraged today, are going to be part of the response to that crisis. I testified before the United States Senate Homeland Security Committee last year, and it was a very respectful discussion, and the senators were very attentive to what I had to say, but there are still enormous obstacles to accessing injectable treatments of any kind in the United States. I'm I can stand here today saying that there's really no obstacles at all here in Canada. We've had Jane Philpott, the previous Minister of Health, has gone to bat removing obstacles and regulations blocking access to diacetylmorphine. And in the summer, a new regulatory pathway came available that will allow access to drugs in an emergency. And as of the summer, at Crosstown, we're accessing diacetylmorphine through that alternative pathway now. But it does require an emergency, and there's no system set up at this time to pay for diacetylmorphine. If it's going to expand, it's going to need to have a DIN or a drug identification number, and domestic production will be required. So we still have a while before diacetylmorphine is going to be widely available in British Columbia or in Canada. This is one of the senators in Ottawa. He is a former Ottawa police chief, and he's applauded Ottawa Inner City Health, which started providing injectable hydromorphone in September of this year. So that was the first clinic outside of British Columbia to provide injectable opioid agonist treatment. And this is from the Edmonton Journal just last week. Alberta has approved a pilot program with injectable opioid therapy, and they've announced that they're going to be opening injection hydromorphone clinics in Edmonton and Calgary. Conclusions. So, injectable opioid agonist treatment, whether it's with diacetylmorphine or with hydromorphone, is an intensive treatment. It's an option for those who continue to use street drugs with all the risks that entails, including injection-related infections and obviously overdose and death. It substantially reduces people's need for street drugs. It reduces crime, leads to more engagement with healthcare and with allied services. And in jurisdictions where diacetylmorphine is not available, hydromorphone is an alternative. Thank you.